Hi, it's Dr. Jessica McLaughlin. Thank you so much for joining me. This is another rendition of our Facebook Live where we take an opportunity to focus on a specific topic, and it can be a little bit of kind of an education time and also an opportunity, it's live, so to kind of ask questions. So I do have someone helping me today, Holly, and you can kind of type in questions and we'll make sure we go through those at the end. So thank you for joining me today. The topic today is recurrent pregnancy loss, which is an important topic. I think many women have struggled with a miscarriage or miscarriages, and so I just want to make sure we've gone through some evaluation and treatment kind of options within recurrent pregnancy loss. Tomorrow is actually a special day. Tomorrow is Rainbow Baby Day, and what that means, it kind of acknowledges women who have had past losses and the new hope for new beginnings when we have a pregnancy and a child after that. And I think a lot of what we do is about hope and new beginnings, whether that's infertility or recurrent pregnancy loss, and we want to honor that tomorrow and, shed a little light on this topic today. So what we're going to go through today, we're going to, kind of first define what is recurrent pregnancy loss, go through, what's a very standardized kind of medical evaluation for that, and then also kind of talk about some treatment options. So miscarriage in the first trimester is very common. That's, one thing to know. It, depending on how you define it, is 15 to 20% of pregnancies result in early pregnancy loss. Across all losses, 80% happen in the first trimester. So what the first trimester means is kind of less than, kind of 13 weeks. So it's very common most of the times that happens in the first trimester. The most common reason for a miscarriage is physically the chromosomes do not come together in the right way. And so most of the time that's random. And so I think about it that the machinery in the ovary, has been sitting there before you were born. And so it can make mistakes. It should only grab, 2 chromosomes and it grabs 3. That's a trisomy. Or it should only grab 2 chromosomes and it grabbed 1. That's a monosomy. And so the, abnormal combination of chromosomes is the number one cause of miscarriage. That does increase with age. So you can just imagine that the ovary starts to make more, and the machinery in the ovary is kind of making more and more mistakes as a woman ages. So that's why miscarriage rate will also increase with age. So it is really not uncommon to have one miscarriage, but when you have more than one, that's really a separate category of what we call recurrent miscarriages. It used to classically be defined as 3 or more, and now we think about it with 2 or more miscarriages. And really that's actually a small percentage of women. So, really probably, in a kind of 4% range have kind of more than 2 miscarriages. More than 3 miscarriages is really, in a 1% range. So overall, a small percentage of women. And once we get into that recurrent miscarriage category, that's really a reason to make sure you see a doctor, because there is a very standardized workup we want to do in that case. And now within recurrent pregnancy loss, we find something in our workup about 50% of the time. And so I always like to start there, because sometimes we find something that is identifiable and correctable, but sometimes we are going to be in a category of unexplained recurrent pregnancy loss, and it's important to kind of know that we don't always find something, but because some things really are identifiable and targetable, we do want to do that evaluation. And so when we're thinking about reasons for recurrent miscarriage, I think about big categories of reasons. So there can be some immune causes of pregnancy loss. I'm going to talk through each of these in detail. There can be genetic causes of pregnancy loss. There can be anatomic causes of pregnancy loss, or hormonal causes of pregnancy loss. And then we're going to kind of dive into, each of those a little bit more. So again, this is something that is within, kind of the specialty of reproductive endocrine and infertility. So we do want you to see a doctor kind of for this, just to make sure the correct workup is being done. So kind of starting with what immune causes could cause recurrent miscarriages, the main thing we think about is something called antiphospholipid antibody syndrome. So these are antibodies that a woman may carry. I can test them in your blood that have to do with an immune vascular connection for pregnancy. If these antibodies come back positive, that's who benefits from being on a blood thinner during pregnancy. That's a combination of aspirin and heparin, or aspirin and Lovenox. Those are blood thinning medications. And so to make that diagnosis, you have to have the pregnancy loss history in addition to the positive blood test. And that is a specific group of women who really benefit from being on that treatment with a positive pregnancy test. In that specific group of women that are positive for that, that improves outcomes by about 50%. So I think about that again as an identifiable, correctable. I can make this better with some treatment, cause of pregnancy loss. So I would certainly, recommend that for all women who have had more than 2 losses in the past. The other thing is kind of this category of genetics, and that sounds a little bit confusing because we initially talked about how genetics are the #1 cause, but there is a small category of genetics that is specifically related to something in the parent. So again, most of chromosomes coming together abnormal is random. It is age related, but is random. And about 5% of the time, a parent, that it could be mom, that could be dad, carries something in their chromosome called a balanced translocation that is currently balanced, and so you're not having any symptoms of it, but when chromosomes come together, they come together in a balanced or an unbalanced fashion. And so that can be about 5% of all recurrent pregnancy loss. To look at that requires a blood test called a karyotype. And so that would be something we talk about, kind of adding on. From an anatomic standpoint, very important to really look at the uterus. So I love ultrasound. I do ultrasound all the time. The ultrasound is a great tool so that I can see the outside of your uterus. So I'm able to really see the outside. Are there big fibroids? Is the shape of the uterus normal? But what an ultrasound really is not good at is looking at the inside. So I need special tests to help me with that. And I always think about, I think the easiest analogy is that the uterus, when nothing is in it, is a closed paper bag. So I need something to really kind of open that space and see on the inside. And that's how I'm going to identify both, is there a reason for miscarriage in there? A septum, we'll talk about kind of what that is, or potentially is there scar tissue after miscarriage? I'm kind of on the lookout for both of those. So we're going to do a test that helps us to see the inside of the uterus. That can be an x-ray test called an HSG. That's where I put a little catheter in the cervix, where I put some dye on the inside. Great information, just as a screen next to us. Can see the inside of the uterus in the tubes, versus something called a saline sonogram, just water on the inside, so I can see on the inside of the uterus, and we'll kind of check those things. So there's a couple of screening tests we can do that are kind of a next step up from an ultrasound to really be able to see the inside of the uterus. A common anatomic reason for miscarriage is anything that can affect the inside. So just imagine something on the inside that really doesn't have a normal vascular supply. That could be there's a fibroid on the inside, potentially a polyp on the inside, or that other anatomic thing we think of is something called a septum. And so what a septum is, it is a remnant of tissue that should have reabsorbed during a normal development of the uterus. And so the uterus comes from 2 poles, it comes down, it meets in the middle, and this middle portion of the inside of a triangle should reabsorb, and for some women that doesn't. And so in older studies, a uterine septum has been found to be associated with miscarriage, just because that, again, is not a normal implantation, spot for an embryo. It's possible to have normal reproductive outcomes with a septum in place, but certainly in the specific population of a couple coming to see me with a couple of miscarriages, plus having the septum, that would really be something we would talk about potentially surgically correcting, and we would talk about that in kind of great detail. The last component is hormonal things, and so that's, taking a deep dive, looking at ovaries, and so that can be thinking about egg quantity and egg quality. Now, egg quality is just our birth date, and so that, really plays quite a big role, from changes that happen at the level of the ovary and increased miscarriage rate. We have some labs to do that really help me also look at egg number. I can look on ultrasound to count the number of little eggs, and I can also do a couple labs. One is called an FSH. That's the hormone that comes from the brain to talk to the ovary. That is classically the menopause hormone. So in menopause, the hormones in the brain are working on overdrive because they're trying to compensate and push the ovary. So it just lets me kind of track where the ovaries are. The other one is called AMH. AMH is a hormone that's produced by all the little microscopic eggs in the ovary, and kind of is my overall, marker from an egg standpoint. Certainly, when we have underlying medical conditions that are not well controlled, those can contribute to miscarriage. So that's when we have kind of diabetes that is not well controlled. We have thyroid disease that's not well controlled. So within that category of, hormonal things, certainly, a new diagnosis of uncontrolled thyroid disease or diabetes, can certainly affect miscarriage. Something that's a little bit new in our field is some new guidelines regarding what's called subclinical hypothyroidism. That is kind of the category of thyroid disease that we've spent a lot of time thinking about, honestly, in my kind of fertility world. It's the kind of category of thyroid disease where we don't have true thyroid disease yet. It's not true hypothyroidism, but one of the hormones, TSH, is a little bit elevated, but still the actual thyroid hormone called T4 is normal. And so we used to think that this had a role really in infertility and potentially a role in miscarriage. It used to be something that I would, screen for, particularly in my recurrent pregnancy loss patients. But as we're kind of learning more, and that's, why we keep studying, why we keep learning, we want to kind of, figure this all out. Specifically in that subclinical hypothyroid population, we don't think that is an active cause of infertility or an active cause of miscarriage. Again, that's different from true thyroid disease. That is definitely something to be managed by an endocrinologist, and making sure we're kind of optimizing that before pregnancy. So those are really kind of the main categories that we think of, from a evaluation standpoint. I would say things like, sometimes I have patients coming in and asking for, a whole range of kind of coagulation testing. Really the main, immune and, things having to do with coagulation are those antiphospholipids. Certainly if you personally have had a blood clot, or there's other kind of factors, but, screening for factor V Leiden and some other, blood clotting disorders is really not indicated just based on, the history of pregnancy loss, just because, if we identify that, we don't think that that would necessarily affect that by treating it in the future. So that would be a very standardized evaluation. Generally, that takes about a month to do. So I think sitting down with a doctor, going through history and going through some evaluations, but those are some things, your doctor may talk to you about from an evaluation standpoint. And then when we think about treatment, we are looking for some, potentially identifiable things in our evaluation. So if we are finding those, we're going to treat those. So that's meaning giving a blood thinner if we're having antiphospholipid antibody syndrome. If we do find what's called that balanced translocation in the karyotype, you can potentially identify that small little area that you carry and do an IVF cycle where we have an actual embryo. We can test a few cells from the embryo to that, specific translocation that you carry to make sure we're not passing that on. So that's a very specialized test where we do IVF. Again, we're getting eggs, we're combining with sperm, we grow out embryos in the lab, and at a certain stage, the embryos can be biopsied from future placental cells. We can look at number of chromosomes, but when we are looking for something very specific, like a translocation, a small change in the karyotype, we can also look for at that time. So these, are patients that are coming to me, or we identify a balanced translocation, we can potentially look at that in an embryo during an IVF cycle. So that would be the treatment or a treatment option, kind of in that case. When we're finding anatomic things, we want to do everything we can to normalize a uterine cavity if it's something that can be surgically corrected, meaning if there's a fibroid in there, if there's a polyp in there, we would kind of take that out. With having a uterine septum, that is something that there is a surgery for, and so it's generally a triangular extra piece of tissue. And so using ultrasound guidance and microscopic scissors, you cut along that kind of piece of tissue to help kind of restore the uterus to a normal configuration. So if, there is something anatomic we're finding, we're asking ourselves, is this something amenable to kind of surgical correction? And then certainly, I think kind of hormonal things potentially kind of go hand in hand with kind of underlying health things. So, if you do have underlying medical kind of diagnoses, whether that's, hypertension or diabetes, whatever that is, we definitely want to optimize those to the best of our ability. And then also learn about where the ovaries are. Unfortunately, I can't wait till we figure this out, how to reverse ovarian aging. We don't have that figured out in medicine yet, but it's important to understand where your ovaries are, especially when we're thinking about kind of treatments and, expectations, kind of going forward. I get a lot of questions about some of these other treatments that, maybe are not kind of standard of care things. That's kind of IVIG or different kind of supplements. There's a bunch of, very honestly, immune things we don't understand yet, but I would say none of those things, very importantly, are standard of care or well studied. And so, for example, IVIG could be more harmful than it could be helpful. And so, our recommendation is we're not ignoring that there is more to learn. But, I think those things at this point could be more harmful than helpful. I think during this process, to acknowledge, psychological components is really important. And so this can be a very stressful, process, for an individual and for a couple. I think to reassure you at this time, we don't think that stress or depression is specifically causing your miscarriage. So you are not causing a miscarriage. I would just take that right off your shoulders. But it's important that you feel supported during this process. So that is another thing to talk with your doctor about. And we work with some wonderful kind of specific kind of fertility related, psychology teams, and have some nice resources to make sure that we're getting, the best support during this process as well. So that's kind of our category of we found some things and we're going to work to kind of make those better. But what if we don't find anything? That again is kind of our unexplained recurrent pregnancy loss category. And there's a couple options. Now, for some couples, in an unexplained infertility or recurrent pregnancy loss category, it's very appropriate to just continue to try on our own. And so this is, of course, dependent on age, this exact statistic. But for a lot of couples, if you continue to try, there's a high chance, whether that's 50%, 60%, of kind of finding success in the future. And so sometimes it's, doing the correct workup and then really, what we call expectant management of recurrent pregnancy loss, continuing to try on our own. Happy to give progesterone supplementation. We know that pregnancies love progesterone. That does support a pregnancy. Our older studies said that was maybe this was the ticket for miscarriage. Unfortunately, it's not going to change if the chromosomes didn't come together correctly. In our biggest study, there really was not a difference with adding in progesterone. Still, I think it's an overall small intervention that may have slight benefit. I don't think it's certainly going to hurt. So if we wanted to add in progesterone supplementation, that is something we can do. We generally start that about 3 days after ovulation. So that could be, a small thing. The other kind of categories of what to do with unexplained recurrent pregnancy loss, meaning we could potentially do an IVF cycle to have the ability to test an embryo for number of chromosomes. So when we think the chromosomes not coming together correctly is playing a big role, this would allow us to do a screening test for that. And so again, what IVF means is a woman has a group of eggs each month. The natural process is that one will grow and ovulate, the rest dies off. IVF means you grow all the eggs that month. So we would grow all the eggs that month, do a procedure called an egg retrieval to get the eggs. We would combine eggs together with sperm in the lab. We'd grow an embryo out for 5 to 6 days. At a stage called a blastocyst, believe it or not, an embryo is about 200 cells. We can biopsy outside future placental cells. We physically are taking out maybe 4 or 5 cells, and we're going to check the number of chromosomes. So this is a screening test for what we talked about, those trisomies, the monosomies. It's the number of chromosomes not coming together correctly. It's a big overview, meaning I can just see the number of chromosomes, but I can't see the genetic sequence that puts together the heart or tells me about birth defects or promises me a healthy baby. So it certainly gives me a huge component, but we have not yet, found a test that will, really let us look at that level of detail. So when I have a, embryo that has screened euploid or chromosomally normal, generally that embryo has about a 60% pregnancy rate going back, and miscarriage rate is maybe 7 to 10%. So again, going back to miscarriage, the risk of one miscarriage in the general population is, about 15 to 20%. When we have more than 2 miscarriages, again, this statistic is going to be different from age, but approximately that's 25% and maybe up to 30%, after having 3 miscarriages. So doing IVF will at least let us kind of screen for a number of chromosomes. And so that would be, another, potential treatment option. So again, we went through kind of some evaluation, things, also some treatment things. Just the last thing I would certainly say about treatment is just optimizing, any possible factors we have to, be living our healthiest lives. That's, diet and exercise. There's not a specific fertility or miscarriage diet, but I want you to think about the diet that you are going to continue when you're pregnant, and you're going to continue when you're chasing your 1-year-old around. So these are sustainable, healthy habits that you're going to show that your children that you're doing kind of the right things, and that's, how to live a healthy life. Same thing with exercise. And so when I think about, trying to optimize weight for, from a miscarriage standpoint, certainly fertility and miscarriage does increase with increasing BMI. I would not use that as a blame game. This is not the blame game, but I would use it as this is something I could potentially optimize going forward. So it's more about what could I do. There's a lot we don't have control over, but certainly from an alcohol standpoint, from a smoking standpoint, no smoking, moderation of alcohol, moderation of caffeine, and living, healthiest habits from a diet and exercise standpoint, and taking those kind of small steps towards being as healthy as we can be. There's not a special supplement to take. I want everybody on a prenatal vitamin. I wish there was a special fertility or miscarriage supplement, but very genuinely, I think things that are not FDA regulated are, again, going to potentially hurt us more than they're going to help us. So it's mainly just the prenatal vitamin from a supplement standpoint. So in summary, I think seeing a doctor who specializes in this, because this is a medical diagnosis. You haven't done anything wrong. We want to do a very standardized workup to help you to see if we can find a reason for the miscarriages, and then be very thoughtful when it comes to kind of what would be some treatment options, kind of going forward. So I'm going to pause there for a moment and see if anybody has any questions.
We do have one from Bianca. She wants to know, urea plasma found positive after testing. Can this be a factor in recurrent miscarriages? tests.
Yeah. So they have more and more tests that look at potentially different components kind of the uterus. And so, really there's probably at least a normal component of each of these in what we call the uterine biome. And so it would be kind of seeing if we think that is to the extent that that is a problem or not. I think specifically that is not known to be a cause of miscarriage, but I would ask, a question and do further testing. Is this specifically associated with what we call a chronic inflammation state of the uterus, chronic endometritis? That is a very uncommon cause of miscarriage, but is, something we would potentially treat. So I think they are continuing to work on kind of specific uterine biome testing to understand that a little bit better. Things like vaginal, kind of probiotics, none of that is quite kind of mainstream yet. So, my recommendation would be to identify if we think that's associated with a condition in the uterus, such as chronic endometritis, and then really treat that as appropriate.
Okay, we have another one from Charlotte, and she says, if multiple complete blood workups, SIS ultrasound, and hysteroscopy have been done, and showed nothing, what would be the next steps if it has already been determined that the sperm is not an issue? With already using progesterone and aspirin, is there another step, or would that fall under the category of unexplained?
So I think, it sounds like someone's, started an evaluation, which is wonderful. I think we've had some testing for the inside of the uterus. So I would make sure those other tests have been done in a thorough way, kind of looking at kind of those other components. But if in the end everything's normal, I do think age is a big factor. And so kind of looking at an age standpoint. But if everything's kind of normal and we're overall in a younger potential category, I do think, kind of one of those two options of, kind of just trying on our own with progesterone supplementation versus, some couples are just kind of ready to take that next step with the ability to kind of test embryos. And so I think, certainly kind of worth a discussion. And I think sometimes when I'm having these discussions, it feels very definitive, but just know it doesn't have to be. So a lot of times I'm having couples where we say, honestly, good news that we haven't found anything. Why don't we just see what happens if you are wanting to try on your own? Let's just see what happens for 3 months or kind of 6 months. I'm going to be here. So, we can always regroup along the way, kind of if needed. So I think, worth a discussion of options with your doctor.
Okay, and then I have another one from Allie. After 2 very early miscarriages, I had a laparoscopy. Yes, where they found stage 2 to 3 endometriosis. The doctor removed most, but had to leave endo on my uterus and bladder. Trying to figure out if I'm likely to keep having miscarriages because of this, or if there's something you'd recommend.
So I think that's a really good question. Endometriosis is really an inflammatory condition of the inside of the uterus. It's normal tissue in an abnormal location, and that can affect egg quality. That can affect, kind of some anatomic distortion. So I think kind of understanding things from an anatomic standpoint are going to be important. That's the inside of the uterus. That's the tubes. I think that endometriosis can affect egg quality, which also potentially can affect, things like miscarriage. I will tell you that connection is not definitive in any way, meaning that, there isn't a study that says endometriosis increases miscarriage, X percentage, but I do think it's possible. So the right thing to do would be completing a full fertility evaluation, knowing what anatomic factors are present. With natural conception, or even simple fertility treatment, if we get you to ovulate an egg into the endometriosis environment, potentially that is being affected by endometriosis. Sometimes for anatomic reasons or wanting to avoid the abdominal component of the endometriosis, we are bypassing those components with IVF. And so again, my kind of next step, recommendation would be understand all the fertility factors specifically related, especially to kind of anatomic things, and whether, we want to continue to kind of try on our own or think about other treatment options.
That's it.
Okay.
Good questions.
Yeah, great question. Everybody's bringing their A game for lunch today. I love that. So I think this is, honestly an integral part of being a physician, that we have kind of these opportunities for education. And so we're going to keep going.
I just have one more.
Oh, yeah, one more.
Okay, Michelle said, I've just had my third miscarriage in the this past November.
Oh,
I have
I'm so sorry.
Anaphospholipid. So as soon as I get a positive pregnancy test, I immediately started Lovenox, and I take baby aspirin daily just in case. I just turned 39. Is there anything else I should be doing? I also just started taking uniquinol, the active enzyme in CoQ12.
Yeah, so I think if we do have antiphospholipid antibody syndrome, certainly the recommended approach is using kind of aspirin plus heparin or sometimes Lovenox is used as an alternative. Important that you are monitored very closely during that time, because a doctor is going to want to follow an ultrasound as we're taking a blood thinner. We want to make sure pregnancy is progressing kind of normally. So, following very closely, and then probably seeing a high-risk doctor, kind of along the way. They're going to help with kind of delivery planning and those sort of things, but there is no additional supplement to take right now. Ubiquinol, is also not a standard of care thing, so just your prenatal vitamin, is perfect.
Okay, and I think that's it.
Okay. All right, thanks guys. I hope to talk to everybody soon. Hope everybody's having a great summer, and we'll talk to you soon. Bye.